Welcome to Discussions with Dr. G. I am Dr. G, your sarcastic pharmacologic nerd, getting ready to lead you on a journey through antidepressants today. So let's kick things off with everyone's favorite apocalypse scenario, the human brain when it's depressed. And by favorite, I obviously mean this is the sort of thing that keeps nurses up until 3 a.m. So what exactly is going on up there? Well, it isn't just about feeling sad. We're talking about a party that's gone horribly wrong, featuring 3-star neurotransmitters: serotonin, norepinephrine, and dopamine. When these guys get out of whack, you end up with mood disturbances, the fatigue, the pure "I can't even" energy that comes with clinical depression. Now, it's not just chemicals floating around. The neuroendocrine system gets cranky too. Out comes higher hypothalamic pituitary adrenal, HPA, axis activity, more glucocorticoids via increased cortisol, that fun stress hormone. And sometimes your thyroid wants to RSVP as well with those thyroid stimulating hormone changes, or TSH changes. On top of that, the brain's ability to rewire and grow, the fancy term is neuroplasticity, drops off. Turns out antidepressants, and get this, regular exercise, actually improve your brain's ability to bounce back. Who knew? And let's not forget genetic risk. If you've got depression in your family tree, you might have drawn the short straw for that too. Add in inflammation and cytokines and your brain network hiccups, and anyway, it's a lot. Of course, all this funky brain action isn't just about feeling blue. It comes with real, measurable impact. I mean, higher pain sensitivity, less immune function, increased heart attack risk, and tragically, a massive jump in suicide risk. 17 times higher. That one always sticks with me. You'll see issues like hopelessness, insomnia, decision-making problems, and chronic fatigue. If you've ever filled out a PHQ-9 or even glanced at the Hamilton rating scale, you know we try to track just how much these symptoms wreck a person's day-to-day. Honestly, my big first wake-up call came when I had a patient whose main complaint was crushing fatigue. Everyone thought she just needed rest, but nope, it was major depression hidden underneath all those exhausted sighs. Just goes to show this stuff doesn't come with a neon sign. So, hold on tight. Let's break down the 7 major classes of antidepressants. Don't worry, I'll keep the big words to a minimum and the bad puns to a maximum. Because, well, why else would you listen to me, right? So first up, selective serotonin reuptake inhibitors, SSRIs. Think fluoxetine or Prozac, the granddaddy of this class. There's also sertraline, paroxetine, citalopram, and escitalopram. Basically, if it ends in INE or PRAM, odds are it's an SSRI. These are your classic first-line drugs for depression, anxiety, OCD, PTSD, panic, even bulimia. If you don't know the name of an antidepressant, just guess an SSRI and you'll probably be about 80% right. But don't actually do that on your exam, okay? Anyway, they're generally pretty safe, but let's just say you're not winning any prizes for libido when you start these. Sexual dysfunction, weight gain, nausea, that's just Tuesdays with SSRIs. If serotonin alone isn't getting the job done, there's selective norepinephrine reuptake inhibitors, or SNRIs, like venlafaxine, which leads the pack. But duloxetine is the one you'll probably see for chronic pain or neuropathy. They pump up norepinephrine along with serotonin. Bit of a trade-off, more pep, but also potential for higher blood pressure and, my personal favorite, night sweats. Then there are norepinephrine dopamine reuptake inhibitors, or NDRIs. Bupropion is the poster child here. This one works on dopamine and norepinephrine, which means fewer sexual side effects, and it will make you gain 10 pounds just by looking at carbs. Fun fact, It's the only antidepressant marketed so heavily for smoking cessation that even the Quitters hotline could recite its generic name. Bonus points. It is less likely to kill your sex life or pack on those infamous antidepressant 10 pounds. It is a hit for clients worried about those side effects, but heads up, it is absolutely off the table for folks with seizure disorders or eating disorders. Now, we have mirtazapine, which is a noradrenergic and specific serotogenic antidepressant. It's an NASSA. This is basically a sleeping pill disguised as an antidepressant. It's super helpful for depression with insomnia, or when you want to see your patient's cheeks plump up on the calorie scale. Yep, you got it. Weight gain is a feature, not a bug. Okay, then there are serotonin antagonist and reuptake inhibitors, or SARI, S-A-R-I, like trazodone. Nobody prescribes this at a high enough dose to treat depression, but boy, it knocks people out for insomnia, and every so often it can cause priapism. I had this one patient who, I'm not making this up, told me, since starting trazodone, I dream in Technicolor now, but hey, at least I finally sleep. If only the Oscars had a category for vivid dreaming. With SARIs, you also got to look out for bleeding risks, especially if your client is already on anticoagulants. For the brave, tricyclic antidepressants, or TCAs, like amitriptyline. They are older, and yeah, they work, but now we're talking about big anticholinergic issues. Dry mouth, constipation, and you do not want to mess with these if there's any cardiac history whatsoever. TCAs can put the cardiac in cardiac arrest if you're not careful. Fatal arrhythmias are no joke. Lastly, the monoamine oxidase inhibitors, or MAOIs, like selegiline. This is your grand finale. You get lab coat bonus points if you can remember you can't eat anything with tyramine or you risk a hypertensive crisis. I hope your patient enjoys tyramine-free diet as much as you love reading food labels, because that hypertensive crisis really is no joke. Tyramine is found in foods like aged cheeses. Think hard cheese like cheddar, Parmesan, and Blue. Processed or shelf-stable cheese like regular American and Velveeta. Every cured meat on the market, salami, pepperoni, bacon, smoked meats, ham, bologna, hot dogs. Fermented foods such as kimchi, tofu, sauerkraut, miso, soy sauce, and even in certain vegetables like avocado, eggplant, olives, and pickles. Oh, and if you thought I was done, don't forget there are fruits like raisins and overripe bananas. Then you have your delicious foods like chocolate, wine, beer, and even Worcestershire sauce. Basically, if it tastes good, you can't have it anymore. So, 7 classes and not one miracle cure among them. But there are lots of tools in our toolbox, and sometimes, like with bupropion in smoking cessation or duloxetine with chronic pain, these meds have bonus powers that can save your bacon. You know, that bacon that you can't eat if you're on an MAOI? Anyway, it's all about weighing benefits, risks, and what someone can actually tolerate day to day. Okay. So how do these meds actually work? I always say if you can remember 3 neurotransmitters, you're already ahead of half the folks in the pharmacology class. Serotonin, norepinephrine, dopamine, right? Okay. SSRIs block the reuptake of serotonin, right? What that means is more serotonin hangs around the synaptic space. SNRIs block both serotonin and norepinephrine reuptake. And DRIs go for norepinephrine and dopamine. You catching the drift? The rest are like a Swiss Army knife of neurotransmitter actions. Mirtazapine blocks certain serotonin receptors to pump up serotonin and norepinephrine releases. Trazodone blocks both reuptake and antagonizes a serotonin receptor. TCAs Those are all over the place. Block serotonin and norepinephrine, sure, but they also hit histamine, muscarinic, and adrenergic receptors, which is why they've got more side effects than my cats have hairballs. Let's not forget our MAOIs. They bust up that enzyme that eats up all three neurotransmitters, so you get a mix of everything flooding in the brain, which is classy. But raise your hand if you want to memorize all the dietary restrictions for a living. No, thank you. Side effects. Though those you gotta know these. SSRIs and SNRIs will give you nausea, headaches, maybe even some GI drama. And yeah, sexual dysfunction. If someone stops taking their SSRI, don't ask, are you still sad? Ask, are you sleeping okay? Did you get your groove back? Okay. Bupropion, on the other hand, can make you jittery, more awake, dry mouth, even some weight loss. So the anti-SSRI, kind of in a way. Mirtazapine, happy problem is sedation and weight gain. Trazodone, the risk of priapism, especially if your patient reports an erectile event lasting longer than medically reasonable. That's a red flag, not a win. TCAs and MAOIs, they're the king and queen of complications, cardiac issues, seizures, hypertensive crisis, for Christ's sake. Anyway, this list never seems to end. Let me tell you about the time I caught escitalopram-induced hyponatremia. Sweet older lady came in for a regular check. I pushed to get her labs because, low sodium. It's not just on the food labels, right? Turns out her sodium was in the toilet. Caught it before she started dropping like a sack of potatoes. Moral of the story, never ever skip the electrolytes, especially in your older patients who are on SSRIs. So, if you're a nurse, here's where the rubber meets the road. Meds don't magically fix things if clients don't take them, right? And let's not pretend people are always thrilled to swallow something that takes, are you ready for this? 2 to 6 weeks just to start working. Our job is to make sure folks stick with it. Adherence is huge. Plus, new scripts kick up suicide risk for some, especially in those first few weeks. You have to watch your patients like a hawk. Watch their families too, because sometimes the energy to act comes back before the mood really improves. That's not the combo you want if someone's feeling hopeless. Now, suicidal ideation is not just a box on the checklist. This is a real thing. It's why these meds are started low and titrated up slowly. You gotta keep asking, especially when starting or adjusting doses. Have you thought about hurting yourself? It's gonna feel awkward as heck. Please ask. Sometimes it's not about what they say, but what you see. Is their mood suddenly better, but too much better? Don't skip the follow-up. Set up regular mood checks and talk about side effects, especially in those first few weeks. Sometimes the subtle stuff, a patient sits differently, stops laughing at your bad jokes. Anyway, those can be the biggest clues that something needs adjusting. Everyone on your team should know the weird but worrisome signs. Better to over-ask than miss the warning shot. Counseling on the side effects is another big ticket. And if someone's on an MAOI, you better go all in on explaining why the charcuterie board is suddenly off limits. There's a lot to watch out for. Serotonin syndrome with a new SSRI or combo meds or SNRIs, hypertensive crisis with MAOIs, cardiac stuff with TCAs. You got to teach clients to recognize warning signs and actually feel comfortable telling someone if things go off the rails. And please, please, please don't let anyone stop meds cold turkey. You'll be seeing withdrawal symptoms faster than you can say rebound to depression. I love using the teach back technique for this stuff because, let's be real, most people remember about 3% of what you say after discharge. Getting family on board is key, especially if you know your client's likely to get creative with their medication schedule. Case in point, recently had a client that started looking a little too sweaty and agitated after a new med. We caught serotonin syndrome early, mainly because his sister remembered from our teaching session what to look out for. Nurses, we're the ones on the lines. We're on the line, right? Catching this stuff that can turn serious. Remember, patient safety is a group project, not a solo act. There's no shame in double checking or nudging a colleague to follow up on a question. And that goes for students, new grads, and yeah, old timers like me too. That's pretty much the highlight reel for today. Depression's messy roots in the brain, the wild world of antidepressant choices, and nursing's make or break role in keeping the whole show from going off the rails. Thanks for listening, and don't forget next time, we'll tackle another big hitter in the world of behavioral health medications. Until then, keep fighting the good fight, and maybe double check what's on that cheese platter, just in case.